Hello and welcome to the CAPE training program. My name is John Leatherman. CAPE is short for Community Assessment and Education to promote behavioral health planning and evaluation. This training and related activities was sponsored by the Substance Abuse and Mental Health Services Administration, the U.S. Department of Agriculture, and the USDA network of regional rural development centers. The objectives of the program are to enhance behavioral health literacy by offering the Mental Health First Aid Workshop with an emphasis on substance abuse. Our second objective is to motivate the creation of community coalitions to address local behavioral health needs, such as those related to the opioid epidemic. Finally, we are encouraging the notion of formal action planning to create a community roadmap for improving the local situation. In this video, we'll continue our discussion of community action planning by focusing on the opioid abuse problem. We'll start by talking about some general action planning strategies for responding to opioids. Then we'll consider some guidelines for community scale action. Finally, I'll offer a community opioid action plan I've developed. First, opioid action strategies. I've created a handout summarizing a number of action strategies that I've reviewed. It's available on the CAPE website. I was able to find many more state-level plans than community-level plans. The community plans that I was able to find tend to be plans for larger metro communities. Not all ideas reflected will be feasible for a smaller community. Still, they offer a range of options for community action. After reviewing a number of state and community-level action plans, there seem to be a number of common categories that many address. I can't remember exactly where I got all of these from, but most are reflected in an action plan created for the state of Illinois. The first priority is often in relation to encouraging safer opioid prescription prescribing and dispensing practices. The CDC recommends setting up prescription tracking registries. They also offer drug dispensing guidelines for primary care and specialty care physicians. You might see specific strategies such as those listed in the slide, and there might be detailed short-term and long-term actions listed. Most plans recognize the need for general public education and efforts targeted at reducing the stigma of mental health and addiction disorders. Some of what I've read suggests that stigma of addiction is one of the greatest barriers to recovery and treatment, because addiction is an illness for which many blame the patient. Most state plans emphasize the need for better data collection and sharing. Many community plans will also organize community surveillance and tracking to note trends and emerging problems. Nearly all emphasize the need to get people into treatment more quickly and easily. In communities experiencing significant overdose mortality, many are simply trying to save more lives through naloxone administration. It almost goes without saying, but ongoing efforts to combat the flow of illicit and dangerous drugs also is a strategy. Again, fentanyl is emerging as the newest and greatest threat. Finally, many recognize both the risk and the opportunity associated with people who become involved in the justice system. They are a high-risk population. It is when they are in the justice system there is greatest opportunity to offer help and assistance rather than simply punishment. In conclusion, as you think about devising some sort of an action plan, consider these general priorities and strategies and ask what is most needed and whether and how you might be able to contribute. One plan I reviewed was from Windsor, Essex County in Ontario, Canada, just across the Detroit River from Detroit, Michigan. They offer what seem to be best community practices for creating a community drug strategy. Without citing the communities or plans they reviewed, they do offer guidelines they wanted reflected in their plan. I thought they were worth sharing. The first one is actually mine. Many states are taking action to combat the opioid crisis. They are adopting new policies and rolling out new programs. It only makes sense to take stock of what your state is doing and try piggybacking on any initiative the state thinks is a good idea and is willing to support. The Windsor-Essex plan starts with advocating what they call the 4 pillars of an action strategy: prevention, treatment, enforcement, and harm reduction. They go on to assert that any effective community strategy should be both coordinated and comprehensive, balancing public health with public safety. There needs to be involvement from the appropriate leadership. This cannot be an initiative handed off to low-level staff. To be effective requires the involvement of people with the authority to make decisions and to ensure action and follow-up. They also assert involvement of both frontline workers who are dealing with the problem, as well as members of at-risk populations, is a good idea in the planning of any effort. These people know what is happening on the street and how to reach the people who are most at risk. They say an effective strategy will employ what they call a collective impact framework. This is the very notion that underpins our CAPE training. Complex and difficult problems are best addressed by a coalition who are able to contribute on multiple fronts to address the problem. As with almost anything, communication is critical, both in a public information education campaign and between entities working on the problem. I changed this next one just a bit because I don't agree with it entirely. They said they would only employ opioid prevention and reduction strategies that had an evidence base of effectiveness. Ideally, that would be true, but if we are only using evidence-based strategies, we're falling behind. I think we need to be cognizant of what has been shown to be effective and use those strategies as much as possible. But we also need our communities to be laboratories of innovation and experimentation. I say try anything and everything you have the capacity to do. Yes, many failures are likely, but we need more strategies. What we have isn't enough. Finally, they recommend obtaining the endorsement of the initiative from local and state levels of government. They may position a community to gain access to greater levels of assistance and resources. Indeed, to the greatest extent feasible, local and state government officials should be brought in at the beginning to help formulate an opioid reduction initiative. Finally, I wanted to create a sample opioid action strategy to share with you to illustrate how you could possibly approach the exercise. I suggested at the beginning that working toward the creation of a community coalition was a good first step. If you don't have an active coalition, I do recommend that this be part of your strategy. The community action plan that I presented at the beginning outlines how this might be done. Alternatively, if you do have such a group in place, or if it just doesn't make sense in your situation, you can plan for some other objective. It may be something in relation to a specific challenge or group. The CAPE Action Planning Worksheet is a good tool to help organize your thinking. I've created a sample opioid action plan that I completed upon reflection of my circumstance. It's available on the CAPE website. In creating my own strategy, I had to write from my own situation. The opioid crisis is only beginning to trickle into Kansas, and there is little current concern. Yes, we have drug problems, but we only recently had our first fentanyl overdose deaths here in Manhattan. It may be a greater concern in places like Wichita or Kansas City, but not so much here in Manhattan. We do have a rather effective mental health coalition, but they are working on other mental health initiatives. So I decided my goal was to keep Kansas in the lowest quintile of states in relation to drug overdose deaths, even as the crisis is projected to worsen considerably over the next 4 or 5 years. I decided to focus on what I could do over that time rather than create imaginary plans for places where I have no experience. I chose priorities and ideas that cost very little to implement other than my own time and money. I only need the cooperation of my mental health service agency that I've worked with in the past. Finally, 1 or 2 of the 3 ideas I thought to try are just my ideas and would not be considered evidence-based interventions by everyone. While Riley County, Kansas has a very successful mental health coalition, there are 25 other mental health service areas in Kansas. I don't know how many of them have active community coalitions. I know some do, but I suspect others do not. As an extension specialist, I can find out and perhaps help motivate the formation of community and regional coalitions based on the Riley County model. I believe coalition building is considered an evidence-based strategy. The next idea is to work with my mental health service agency and local chamber of commerce to figure out how to engage the local business community to become allies in responding to mental health challenges they see from their employees. I haven't seen employee assistance programs referenced as an evidence-based strategy, but this only makes sense to me as being part of the solution. Finally, I wanted to do something that might address mental health and substance abuse stigma in the community. Some have suggested that storytelling was one good way to help reduce stigma. I've read that real people telling real stories about their experiences and struggles is an effective anti-stigma strategy. I won't go into it here, but you can read about it in my sample plan. So I've given you 2 sample plans, and we've talked a lot about how to work at the community scale. Now it's time for you to take up the challenge. I'd like to encourage you to make an effort to plan your own community initiative. It can be anything you think is needed. It can be your own plan, something you work with others as a team, or something you engaged a larger group of community partners to undertake. In earlier programs, a number of participants were working with community coalitions and wanted their plans to be a group initiative. That, of course, may take some time. So from here, we'll have 2 webinar discussions using Zoom communication technology. The first will be to talk about the community development content you've been watching in this video series. We'll also talk about your community action planning initiative. Then we'll have another Zoom webinar 2 or 3 weeks later where you talk about your ideas for a community initiative. We'll give everyone a chance to share their ideas, and everyone can try to offer any constructive ideas and suggestions. I'll be in touch to arrange the discussion. Contact me with any questions you may have. Thank you for your time. Thank you for your attention.